Good afternoon, ladies and gentlemen. In my first two videos, I have demonstrated how to diagnose autonomic dysfunction in childhood using the 24-hour Holter ECG or active standing test. We have learned how to improve heart rate variability and lowering heart rates in children with elevated heart rates, and now I try to explain how to improve physical performance in children with autonomic dysfunction by using heart rate lowering pharmacotherapy. To understand this, we will recapitulate our three-dimensional view on heart rate regulation. The first is well-known regulation by the autonomic nervous system via parasympathicus and sympathicus. We have learned that most of our nutrition is responsible for a heart rate regulation via the funny channels, and last but not least, we have shown that myocardial performance probably improved with omega-3 fatty acid supplementation and have a further heart rate lowering effect. In summary, there are three systems to regulate the heart rate. The first is the autonomic nervous system using better or muscarinic receptor regulating substances. The next is the regulation by the funny channel using ivabradine, and last but not least, we have the opportunity to regulate heart rate with omega-3 fatty acid supplementation. At long last, we have four systems to regulate the heart rate. Most often, we regulate the autonomic balance, for example, with the beta blocker therapy that is well approved in the heart failure trials. Another possibility is to lower the heart rate via the funny channel with the ivabradine therapy, also approved in the heart failure trials, but this is not the first choice in therapy. Probably via the sodium channel, omega-3 fatty acids have heart rate lowering effects, like shown in my last videos. Another well-approved choice to lower the heart rate is physical activity that lower the heart rate. All these interventions have an effect on prognosis as learned in the heart failure trial. Lessons learned from the heart failure trial clearly show in hundreds of thousands of patients in prospective randomized study that the prognosis depends on heart rate changes in study. And there are the beta blockers who reduce heart rate and improve mortality. And on the other side, there are some other drugs who elevate heart rates with, and the prognosis is worse. But the beta blocker trials clearly show the lower heart rates and the better prognosis in heart failure patients. This heart rate hypothesis is confirmed in adolescents in this Swedish study with 1.8 million of adolescents who are observed within 50 years. And there's a clear impact of the resting heart rate on prognosis of heart failure, with those who have high heart rates develop early heart failure and those with low heart rates who develop late heart failure. This study, published in PLOS ONE, show the impact of omega-3 fatty acids on inappropriate sinus tachycardia in children. There's a clear reduction of the circadian heart rate that is elevated in children with inappropriate sinus tachycardia, and a significant decrease of heart rate was demonstrated after omega-3 fatty acid supplementation. The patients with inappropriate sinus tachycardia in our cohort are those with short stages, with attention deficit disorder, with obesity, and some with hypertension. Those children with congenital heart defect, constitutional thinned, and anorexia nervosa have low heart rates. However, it is not possible to convince an adolescent to eat fish or supplement omega-3 fatty acids to improve his cardiovascular prognosis in later life. We investigate if there are other factors that support these therapies with an impact on quality of life. And indeed, we have seen that children with upright sinus tachycardia have a very bad physical performance in comparison to healthy children and adults who have a very low heart rate and a very good physical performance. The next slide shows our investigation in children with the spiroergometry. This regression model of 110 adolescents who received a 24-hour ECG and a spiroergometry to predict the maximal oxygen uptake index as an indicator of the physical performance. The data clearly show that the heart rate at the start of the spiroergometry should be very low, and the heart rate at maximum exercise predicts the oxygen uptake. There are lower impacts of the heart rate variability in the 24-hour Holter ECG on physical performance. The clinical model of this analysis clearly confirmed the impact of body mass index and competitive spurts as well as age on the maximal oxygen uptake, but the dominant effect based on the heart rate reserve, what is the difference between maximal heart rate and the baseline heart rate in spiroergometry. There's a very high prediction value of this model. Based upon this data, we realize that physical performance depends on heart rate reserve. What is the difference between the maximal heart rate and minimal heart rate during spiroergometry? Probably the maximal heart rate is controlled by the sympathetic nervous system and the minimal heart rate is controlled by the parasympathetic nervous system. The first study clearly showed that heart rate lowering with ivabradine improved physical performance is published by Cabeta et al. In JACC in 2012. He clearly showed that ivabradine reduced heart rate at day, night, and the minimum and maximum heart rate and improve the physical performance in an exercise test. This study was confirmed in other studies. Recently, a study showed that low-dose propranolol improve exercise capacity in children with post-oral tachycardia syndrome. Last but not least, we have the opportunity to improve physical performance in those children with higher heart rates with a heart rate lowering therapy with beta blockers, ivabradine, and probably also with omega-3 fatty acids. By understanding the impact of caloric intake on heart rate and the impact of heart rate on physical performance, we understand the vicious circle of obesity. Those patients have a high calorie intake that induce a high heart rate and low heart rate reserve that further induce a bad physical performance. Due to uh, the bad physical performance, the patient have a low calorie consumption and the body mass index further increase. The improvement of physical performance seems to be very urgent in those patients who suffer from long COVID syndrome. This is a 16 years old girl who had her SARS-CoV-2 infection in 2020 in the first wave and suffer from fatigue and many problems for more than a year. She goes to hospital and nobody knows what is the reason for the problems. We diagnose an inappropriate diagnosis tachycardia is shown in this slide. She had a mean heart rate of 104 with slightly elevated blood pressures. Of course, the high symptomatic burden of the girl, we decide for ivabradine treatment and found a good decrease of heart rate while lying and while standing, but the girl developed headache and lightheadedness during this therapy, and we have to change to low-dose propranolol, who shows a further decrease of heart rate and a very good improvement of vagus activity during this low-dose therapy, and the goal improve the symptoms in the next weeks. These effects are also shown in the fast Fourier analyzers with the highest heart rate variabilities in propranolol therapy, but the complete collapse of heart rate variability while standing that slightly improved with propranolol therapy. This 16 years old girl developed a severe post-oral orthostatic tachycardia syndrome 2 weeks after BioNTech vaccination, and she goes to hospital, but the reason is not found. We analyzed her heart rate variability in 24-hour ECG and found this tachycardia in situations with physical activity. She stopped her physical activity, of course, this tachycardia, and in the afternoon she's completely laying down because of this phenomenon. After ivabradine, the mean heart rate dropped down from 96 to 77, and she has no tachycardia while standing, or slight tachycardia while standing, and we found an improvement in physical activity, and she recovered from this complication. Looking to the active stomach test data, we found an improvement of the tachycardia while standing in the early 2 weeks after the therapy, or 6 weeks after the therapy. There is further an improvement of vagus activity while lying and a slight improvement while standing. The ivabradine therapy shows little effect on heart rate variability measured by the fast Fourier analyzers while lying, but progressive improvement of heart rate variability while standing 6 weeks after starting ivabradine therapy. In that video, I show how to improve physical performance with heart rate lowering drugs. The idea of not spending yourself on the sports field to improve your performance is exciting. However, this therapy works only in patients with autonomic dysfunction. This group of patients quickly increased, not least because of the COVID-19 pandemic. At the end, I hope that the pandemic leads to a return to ethically motivated medicine and the asymmetrical war between economics and ethics in medicine is ended. I thank for your attention.